Hello, everybody. Welcome to our next episode of Cancer Survivor MD. We're very lucky to have a special guest with us today, Dr. Kathryn Schmitz. I have known Kathryn. I was trying to do the math, but that's a little hard to do. I think it's close to, if not over 20 years. She's had a very long standing career in which she makes gradually but steadily progress in making exercise safe, effective, evidence based, and accessible to cancer survivors and meet them where they're at in the hospital, in the outpatient setting. And she has done that in the clinical setting, but also everywhere in between up to the top level of trying to make policy changes that then result in insurance changes. And I'm very, very proud of her. And I was so sad because it was my dream to be able to work with her. But that didn't work out because she came to the University of Pittsburgh right around the time that I had to medically retire. And so right now, Kathryn Schmitz has multiple positions at the University of Pittsburgh. One of them is the professor of medicine. The other one is she's a co-director of the Hillman Cancer Survivorship program. And another hat she wears is the founding director of an exercise oncology program called Moving Through Cancer. She is also the deputy director of the Hillman Cancer Center and the associate director of population science. That before I give a word to Kathryn Schmitz, I should always remind myself that Brad is here with us.
Thank you so much. What a kind introduction. And Josie, I have such fond memories of connecting with you when I was a professor at the University of Pennsylvania. And, we were both involved in a process of the development of a CD that was intended to help breast cancer survivors to do upper body resistance training at a time when it was verboten. And we were bucking the data because we saw that there was real value to having these women be more physically active. And then I came out with the results of a very large trial that showed that indeed it was not only safe, but beneficial for women to do upper body strength training after breast cancer. So we've been tied together and interested in the same ideas for a very long time. So it's delightful to have an opportunity to sit down and chat with you.
Thank you, Kathryn. Brad, would you like to say something or shall I keep going for that one?
I am very delighted to have Dr. Schmitz here, but I would like to hear more about her work and career and research before I ask my incredibly intelligent questions.
Okay. Thank you, Brad.
Well, where to start? Would you like to talk about your exercise oncology program? Where would you like to start, Kathryn?
Sure. Why don't we talk about the Hillman Exercise Oncology program, and we'll talk about kind of where it came from and why I've designed it the way I've designed it and what we're hoping is true based on doing this program. There are programs that are out there across the United States and beyond for cancer patients and survivors, and they're designed in different ways. And, so the Live Strong program at the YMCA is a wonderful, wonderful program that is community-based and that brings cancer survivors together in a group in order to learn how to safely exercise and recover from their cancer treatments. That's a wonderful model. It's a model that works really well for the people who are available at the time that session occurs at the YMCA and when it starts. So that program starts 3 or 4 times a year. It's 12 weeks long, and it's offered, say, Tuesdays and Thursdays at 7 p.m. or something along those lines. So if that happens to work for you and you have that program near you, it's brilliant. And so that's great. And people who can't enjoy that program should. And, I'm a huge fan of the Live Strong program. What we were interested in was trying to fill in the gaps for the people who don't either have a Live Strong program near them or for whom getting to a program at, Tuesdays and Thursdays on in the evening or whatever the timing ends up being doesn't work for them. And so how do you meet the needs of somebody? Because, that's not how we practice medicine. We don't offer people chemotherapy on Tuesdays and Thursdays at 7 p.m. We offer it to them according to appointments because it's urgent. We want to make sure that it's going to happen on an urgent basis. And so we see exercise as an urgent issue. And so what we've done is we've developed a triage tool in collaboration with some folks that, developed a really long version of it. We made it shorter and easier to implement within the clinic. And the medical assistants ask the patient these 6 questions when they come in for an infusion visit for chemotherapy or immunotherapy. Based on the answers to their questions, a staff person from my team approaches the patient and says, hey, it looks like you're having some difficulty climbing stairs. You're having difficulty with numbness and tingling in your feet and your hands, or with fatigue, or whatever the issues are that they report on the survey. And we can help you with that. And we then triage them to either be referred to physical therapy, or we develop a home exercise program for them that is specialized to their particular needs, or we refer them to community programs like Live Strong and Y. And that's generally for the ones that have less urgent issues. We find that about half the patients are getting referred to a program like Live Strong, and the other half we're doing some kind of program for them at home or sending them to physical therapy. We've been doing this program at the Shadeside location of Hillman Cancer Center for 3 years now. There is also exercise oncology programming available through Hillman at Newcastle as well as at Erie. The Hammett Foundation has very kindly funded a staff person for the Moving Through Cancer program at the Erie location of Hillman for the past year. We've seen over 2,000 patients now doing this program, and we feel like we've learned a lot about what people are interested in, what they're not interested in, and what works. We've pivoted a number of times in how we're delivering the program so that if somebody thinks they just want to kind of do it on their own, then we can give it to them just kind of on their own. If they're like, I think I might need some support, then we can do some telehealth sessions with them if they're interested. We can do phone counseling if that's of interest. So we try to meet people where they are, including recognizing where they are behaviorally, where they are clinically, and where they are in terms of sort of social issues. We recognize that just because you're dealing with cancer doesn't mean that you don't have a parent with Alzheimer's or a child that's going through a difficult time. There can be a number of life issues that are happening. And so what people are really ready and willing to do with exercise during and after their cancer treatment varies a great deal over time. So we're trying to be very flexible to help them get the best possible function and symptom outcomes from exercise, while at the same time recognizing that it's a complex time going through cancer.
Thank you, Kathryn. I see Brad turn his camera on. Brad, would you like to ask a question?
Sure. So as you can see, or I hope you can see anyway, I'm literally wearing my Man Up to Cancer hat as we speak, which is a reminder to ask the question to Dr. Schmitz about gender and exercise. And so the reason why Man Up to Cancer exists, it's a support group for men going through cancer. The reason why this group exists is because men don't join other support group same rate that women do.
Yes.
And so I'm wondering if that is also true for your exercise programs. And if that is the case, then what, if any, steps can be made to bring men into that space so that they can benefit from all the wonderful work that you've been doing?
Yeah. So we find that in the literature, what you find is that men are less likely to join group activities after a cancer diagnosis. And that's exactly why your organization exists. But we find that we actually do pretty well with inviting men to do an exercise program because we're doing it with them one-on-one. And so it's less of a group activity. And so there's less of that, that sort of initial barrier that some gents might feel in approaching something that's in a group setting. So that's actually gone really well for us. And one of the places where it's gone particularly well is with our older patients. So we have a 12-week telehealth program that we do for older patients. And we find that our male participants do really, really well and really enjoy the program.
Are there specific activities that men might be more inclined to engage in, than women might? Like what is working to get them in there and keep them in there?
We're really focused on strength training in the Moving Through Cancer program because we know that during cancer treatment, people tend to lose a lot of lean mass, a lot of muscle mass, and that changes your ability to function and climb stairs and alters the way that you respond to cancer treatment symptoms as well. And so I think one of the reasons why our program is done relatively well with men is because we are focused on something that is more stereotypically associated with men being interested in the activity.
You mean strength, right?
Yes.
Right. That is a classic masculine
Yeah.
gender trait, let's say, that will appeal to men. I'm also wondering about the long-term survivorship impact of strength training. Just to give my own patient perspective on that, like I lost a ton of muscle mass during my stem cell transplant, in particular, because I was basically bedridden for months in the hospital.
Yeah.
And I also lost bone density too, because I was on a lot of prednisone and I was diagnosed with osteopenia a few years after my transplant and needed, to up my dietary supplements to compensate for that. I also, I think, got some sort of infusion to address that. But also my understanding is that strength training really helps to try to build, because you can recover some bone density.
You can.
And strength training is part of that. So I'm wondering if you could just say more about that, sort of maybe more long-term
Sure.
perspectives.
The researcher who's done the most brilliant work, in my view, on bone health after cancer is Carrie Winterstone. Carrie has done work both in breast cancer patients as well as prostate cancer patients. And, one of the things that she has convinced me of based on the results of her research is that the kinds of things that we need to do in order to improve bone after cancer, cancer treatment results in osteopenia, osteoporosis, is a combination of strength training and activities that load the bone, like jumping or plyometric activities, weight-bearing aerobic activities. She's done some really brilliant work comparing those kinds of things to things like tight. What she finds is that it is more useful for bone. Bone as an outcome is becoming of interest again because we have some new agents that are coming forward for breast cancer in particular. We don't know what their effects are going to be on bone. We're back in the same position of trying to figure out exactly how best to help those patients. And what we want is to not wait to see that these women end up with osteopenia and with fractures before we actually act on it, because we can very reliably predict based on the action of the drug that there are likely to be problems with the newer drugs. In terms of the long-term effects, and I think you're talking about disease-free survival, the difficulty is that it's, as an epidemiologist, I can tell you that there's no really good way to measure whether people have been doing strength training or not, because unlike with aerobic activity, we say, oh, I ran for an hour, or oh, I ran for 30 minutes. People know how long they went for something that was high intensity like that. But for strength training, we would need people to tell us not just that I strength trained twice a week, but also how many sets you did, how many reps you did, how intense it was. So there's a great deal more complexity to collecting those data. So unfortunately, we have really not great data to tell us whether or not strength training would have an effect on disease-free survival or overall survival. But I suspect, based on the biology, that it would have a very strong effect, as does aerobic exercise.
Yeah, thank you. That makes a lot of sense. If I could just backtrack and get you to explain what you mean by plyometric
Oh, sure.
exercise.
That's
'Cause
the thing where you
term
jump on a box.
Okay, I can't jump
Yeah.
I can't jump over my cat if my cat is in the way. I've lost any athletic
Yeah.
capabilities whatsoever. My knees are shot. Basically, I can't
Yes.
run because of I think primarily it was the chemotherapy and radiation that did it for my knees and in those particular joints. But what about stretching or like yoga or massage? Can any of
Sure.
those things help with any of these? Because I've personally found that massage has been probably the best way for me to feel like a human being again after my various treatments. When
Yeah.
I ended up feeling like I was a sort of a bundle of body parts that had been put together incorrectly. And
Yeah.
I don't know how common that is among other cancer patients. It's very common with stem cell transplant recipients, especially if we've had the graft versus host disease, as I have. But anyway, I'd like to know more about, yeah, like the stuff that's not maybe so athletic, because like I've lost all athletic capabilities. I'm not jumping on any boxes.
Right.
No.
Well, I will guarantee you that if you gave me 15 minutes, I could have you doing strength training. Everyone can do something with resistance, even
Absolutely.
if it's in a chair, okay? And should do some kind of strength training. And because if it's muscle is a use it or lose it principle. So there are still some things that you can do. And, there are weight bearing things that you could do that would be good for your bones. And I would advise it. In terms of bone health, we have zero evidence that massage or yoga would have an impact on bone. In fact, those are things that are used in control groups for the trials. But in terms of the ability to help with symptom outcomes, absolutely. So yoga is a modality that can be used for cancer-related fatigue, anxiety, and depression. It has been shown to be efficacious. It's not as well studied as aerobic exercise and strength training, but it does have value. And massage is really poorly studied. The kinds of research that I do, which is randomized controlled trials, doesn't tend to happen in the world of integrative medicine to the same extent. There's gorgeous data on acupuncture, really beautiful randomized controlled trials, rigorous, beautifully done randomized controlled trials about acupuncture. So we know that acupuncture has real value as well. But the quality of the evidence that I call upon in order to say that something is or is not useful, that evidence doesn't exist for massage. That doesn't mean it's not useful. It just means we don't have the evidence.
Right. Yeah. Well, thank you. No, it's really good to hear what the research is telling us at this time, and yet how much more research can
Needs to be
potentially
done.
tell us.
Yes.
Yeah. I wonder if you could just walk us quickly through like how this works physiologically. Let's say you mentioned the evidence that shows that doing upper body strength training helps with breast cancer patients. What's going on in the body physiologically from your point of view when that's beneficial? Just to a layman, which despite my cancer experiences, there's still a lot of the terminology that's a little bit opaque.
Sure, absolutely. So, breast cancer treatment often includes removal of lymph nodes from the chest wall or from the armpit, what's called the axilla. In addition to that, there's often radiation treatment to the chest wall or to the armpit as well. And those two things, the removal of the lymph nodes and the irradiation of the lymph nodes, can cause damage to the lymph system in the upper body. And the way that the lymph system works in the upper body is that those lymph nodes that are in the chest wall and the armpit are feeding the arm and the hand on the same side. If the lymph nodes are damaged, then the ability of those lymph nodes to help the hand and the arm to communicate what they need to communicate back towards the heart, which is the lymphatic system is a return system back to the heart, is damaged. And so what we know from exercise physiology is that if you exercise a body part, then you are going to grow more capillaries in that area. We know that we grow more capillaries where we exercise, and it's very specific. Exercise your left arm, you'll grow capillaries in your left arm. Exercise your right arm, you grow capillaries in your right arm and only your right arm, right? So what we know is that by doing the upper body exercise, slowly increasing the physiologic stress on the upper body by doing the strength training, then we're probably improving the cardiovascular system. We're improving the number of capillaries and vessels that are helping the lymphatic system to return any kind of debris from cuts or infection or bacteria or anything that gets into the arm or hand back up the arm and all the way back to the heart so that you don't end up with an infection. So we believe that there is really kind of a mechanical effect of the upper body exercise for the arms and shoulders and chest and back of breast cancer patients. How did I do, Dr. Van Landen? How did I do?
You did very good. One thing I would like to add, though, but I don't know if I throw too many wrenches in here, is scar tissue.
Oh, yes. So scar tissue is a particular challenge after breast cancer and can impede range of motion, but also impede the ability of the lymphatic system to do what it needs to do. And so again, by doing slowly progressive resistance training, we can help that scar tissue to be able to loosen over time. And that can be with not just the strengthening, but also the stretching activities that go with the program that I've developed called Strength After Breast Cancer. It's mechanical, even for the scar tissue. I think there's a mechanical aspect to it as well.
This is a topic we can talk about for a long time, but I wanted to delve into something else that is really near and dear to our hearts, is payment. Kathryn, can you comment on your observations and dreams for how cancer survivors can access these exercise services in terms of payments? Like, who will pay for them?
Yeah. So this has been a topic of interest for me for the better part of a decade. And the assumption for a very long time had been that there would always be philanthropic sources that would pay for exercise programs for cancer patients and survivors. And that is still the kind of standard of care, if you will, is that, it should be free and it should be paid for by philanthropy. And so health systems shouldn't have to pay anything for it, and patients shouldn't have to pay anything for it. And so it is then devalued. I believe that with the results of the challenge trial, which was published last year and showed us that in a very rigorous randomized controlled trial, that an exercise program after colon cancer resulted in 27% improvement in disease-free survival and 38% improvement in overall survival, which is more whopping effects than for most chemotherapies. We really need to flip the script here, and we need exercise to be part of the standard of care for cancer patients and survivors. So I've been trying to approach this a number of ways. One of them is through trying to change policies. I've been very grateful to have the opportunity to learn from colleagues at the National Accreditation Program for Breast Centers about the process of writing standards and getting standards to guide the care for breast patients. And they have allowed me to contribute to some of the standards that exist for NAPBC. And, I'm very proud of the collegial work that we've done to develop standards that ask breast programs to do some kind of evaluation of their patients' upper and lower body function while they're going through their treatment so that they get appropriately referred, whether it's to physical therapy or to an exercise program. I've also been really grateful to have the opportunity to work with the Commission on Cancer on trying to see if perhaps there might be room for an exercise oncology standard at COC. And so that's an ongoing conversation. Please stay tuned. We'll see what happens with that. I'm hopeful. And then closer to home, I have been working with senior leadership at UPMC to see whether there might be any opportunity for us to make exercise a covered benefit for breast cancer patients that are employees of UPMC. And so an executive committee decided that they were willing to allow this pilot idea to go forward. And so now a very large team led by Dr. Suzanne Labriola is working on designing this covered benefit and learning all of the things that have to be clarified. How are you billing? How are people credentialed? Where is it going to occur? Are we working with providers that are outside of UPMC or within a UPMC? What does the training need to be of the people who are going to be doing this? There's a number of things that have to be clarified in order for this kind of covered benefit to become a reality. And so I am so absolutely honored to get the opportunity to collaborate with UPMC on these conversations. I can't wait to see where it takes us.
It's my understanding, Kathryn, and I get a little excited now, that this is the first time in the United States that a health plan is considering piloting this with the hope that they will expand it to covering it for every cancer survivor, just like they cover exercise for those with diabetes and those with a history of heart disease.
Yes, that's correct. UPMC is leading the way here.
I'm so excited. Brett, are you excited?
I am so excited.
Well, if I were a breast cancer patient at UPMC, I would be very excited.
Yes.
But
Yes.
no, I mean, obviously, someone has to be the first, right?
Yes.
Someone needs to blaze the trail so that others may follow. I certainly applaud these groundbreaking efforts on your part, Dr. Schmitz.
Thank you. It's been an amazing thing. I came to the University of Pittsburgh and UPMC Hillman Cancer Center in large part because I saw within this place an opportunity for some entrepreneurship with regard to changing how we deliver exercise oncology. And so we've done this whole program that I've talked to you about, which is supported by Hillman Cancer Center and by some philanthropy. And now we have this opportunity to collaborate to see if it's possible to create a covered benefit. It's a pilot for right now. And I have to pinch myself every day talking about it to see, is this really going to happen? We need to get it right too, because if we get it right, then it will become more broadly available. It will form the basis for other health systems to do the same. No pressure.
No, but that's one of the reasons why you're here, to
Yeah.
try to inspire and empower other people to do something similar in their communities. It's my belief, and I'm pretty sure, Brett, Kathryn, you think the same, that an early investment will have a payoff later on. The question is, can we measure that? Can we prove that?
Yes, exactly. So I can tell you that one of the reasons why UPMC was willing to consider this was because of some preliminary data that I published with Dr. Karen Wonders that shows potential for improvement in acute unplanned healthcare utilization with an exercise oncology program as compared to not doing an exercise oncology program. And so we need further data on this topic. And this is sort of very close to my heart. I'm trying to figure out how to get some further funding to examine this.
Thank you, Kathryn. We're not done yet, but it sounds like we need to have you as a recurring guest so you can
Okay.
update us.
I'd be delighted.
So the last topic, we've talked about the exercise providers. We've
Mhm.
talked about the survivors, but then there is an important third group involved in this triangle, which is the healthcare provider, whether it's a cancer provider or a non-cancer provider like the primary care doctor. And I have a feeling that you have a lot to say about the involvement of providers, and so I'm going to leave it as broad as I can.
Yeah, I have things to say. What I want to say first and most importantly is that I think that healthcare providers are really stretched these days in the US. And I think that's true for oncology specialists. I think that's true for primary care providers. And in an ideal world, they would have a lot of training and understand the power of exercise for their patients. And they would prioritize talking to their patients about exercise and tell their patients that they think it's just as important as their chemotherapy. It's just as important as all the other treatments that they're getting. But we don't live in an ideal world. And clinicians have many, many, many things that they need to cover in a very short time that they have with their patients. And so I never, ever want to make clinicians feel bad or wrong about not remembering to talk about exercise, because I think that they have a lot of pressures. What I want is to create the infrastructure so that patients always get support for exercise, and that all the clinicians have to say is, oh yeah, you're going to talk to Dr. Van London, or, oh, you're going to talk to Dr. Schmitz, or, oh, you're going to talk to Ray, you're going to talk to who, whatever. I want you to do what they say. That's all they need to say, like a single sentence. So I want buy-in from the clinicians for sure. I want the clinicians to rigorously review the literature as I have and say, yes, I think this is a good thing for my patients to do, but for them to have the infrastructure in place to be able to support them in getting their patients in the same way that they have, there's a huge infrastructure for getting patients to chemotherapy. Huge infrastructure, right? All those chemo chairs and the poles and the nurses and the medical assistants and the billers and the schedulers and the people walking around with dogs to pet and, hot blankets and snacks and, all of the other things that go along with the chemo infusion suite. We need to create that infrastructure for exercise oncology. We need to, create that same infrastructure so that the physician doesn't need to say much more than, hey, this is really important, and you're going to go talk to Ray about this now.
Thank you, Kathryn. I think Brad is ready for his questions.
Well, I wanted to say amen to what Dr. Schmitz just said, of course. I have a question. I guess I'm sort of returning back to a previous conversation, but this time about neuropathy, which is, maybe the most common lingering after effect among the men I talk to of their cancer treatments. And I certainly have neuropathy too. My understanding is that there is no link between exercise and improving neuropathy, but I could be missing something. And so I'd love you to fill me in on that. And because I know there are people going into their chemo treatments like with cold packs on their hands and feet, hoping to prevent neuropathy. Is there any exercise component that would either help to prevent neuropathy from happening in the first place, or then to treat it or somehow address it after treatment?
Yeah. So there are some researchers in Europe who've done some beautiful, extremely well-controlled aerobic and resistance training interventions for peripheral neuropathy that have shown some promising results. When we then bring that work to the US and people, do the interventions in the US, we're not seeing the same results. We're not quite sure why. So the data are not consistent across the ocean. One of the things that seems to have some promising possible benefit are the vibration plates. Have you ever heard of vibration plate? So the really expensive ones are like $5,000. You go into a facility to do this and you stand on the plate and it vibrates your feet, and they can fine tune exactly what the speed and the depth of the vibration is. And then there's something you can buy off of Amazon for $80 and stand on and it vibrates. And obviously that's not going to have the same exact effect, but there is emerging evidence that there could be some value with the vibration plates. I'm not asking people to go out and get something from Amazon. That is not what I'm saying right now. But there is, just sort of watch this space. We'll see what happens. It's been frustrating not to be able to nail down exercise and neuropathy, because we get a trial and we get a positive trial and we think, hey, great, this is great. And then we get another trial and it's null. And so the people who work in neuropathy would like us to conclude that it helps.
May I offer a hypothesis for why there might be a gap between the European results and the North American ones? My understanding isn't, and this is my understanding, again, from a layman's perspective, but having addressed and sat in on a session of the European Bone Marrow Transplant Association, my understanding is that in Europe, there are maybe fewer cancer and transplant centers per capita, but they are more full service. Each one has more of the wraparound stuff, including all the support, and wellness enhancement things that we would all like to see at all cancer centers. Whereas in the US, it's a little bit of a grab bag. And so not every cancer center here is as well equipped, to offer all of the peripheral services that would make, an experimental treatment supplemented by exercise that would make it successful.
This is a study that I wanted to design about 15 years ago. I had the good luck to have been invited several times to Germany and got to see their, how cancer is treated in Germany and how they do cancer rehabilitation. Their cancer rehabilitation centers are like spas, and everybody goes for 3 weeks and you get the whole treatment. And I just was so astounded. And it really struck me that, wow, it must be that people recover better from cancer in Germany than they do in the US. And so I tried really hard to figure out how to design a study to test that. I'm very interested in what you're saying. I never did succeed in designing and getting that study funded, but I think you're onto something.
Dr. Josie, you may have some thoughts.
I'm trying to keep it together in my head. So for those that are listening, neuropathy is damage of the long nerves due to chemotherapy and other treatments. Sometimes it happens for other medical reasons, but it can present with numbness, which is obviously not painful, but can still be bothersome. There is the painful neuropathy where you can have pain and burning of your feet and your hands. And there is the clumsy neuropathy, is what I call it, where sometimes you don't have full control over the motion of your feet, the fingers, hands. And with that, you may lose balance. And so neuropathy manifests itself in many different ways. And what we also know to some degree is that what you eat and how you move is also affecting how your nerves might have a reserve, but also how they may recover. Then in Europe, the food regulations are different than here in the United States. Obviously, regardless of that, we eat differently here than in Europe. And in Europe, we move a lot more than in the United States. And so I wonder if any of those factors interfered with the ability to see that there is a benefit here in the United States. But I have a feeling this is also a discussion that can go on for a long time.
Very long time.
I like that you brought this up, Brett and Kathryn. I'm really happy that you were here to share what you've been up to and what you're going to be doing to shake up the world. And usually towards the end of the hour, I let everybody have their closing statement, if that is how you want to call it. Are there any last words that either of you would like to share before we close for today?
It's important that people move however they move. And if moving for you is sitting on the front of your chair for 5 minutes, then do that. If moving for you is standing up for 5 minutes, then do that. If moving for you is 30 minutes of walking, then do that. I think that we get stuck on the idea that exercise has to look like CrossFit, or has to look like marathon running or 5Ks or whatever. And exercise can be really minimal and very useful at a very minimal level. And so, start where you are, do what you can, and take it from there.
Thank you, Kathryn. Brett, is there anything else you would like to share?
I have found this a fascinating conversation just in terms of Dr. Schmitz's command of the research and her innovative approach on both a medical level, but also on an administrative and intellectual level. But yeah, we've discussed exercise on this podcast before. And yeah, I will just say, to go on the record, if people haven't listened to that previous one, that, I've lost the athletic side of Brad that used to exist when I played soccer and ran every day and so forth. I do lift my 10-pound and 5-pound weights every day, and I hate it. I don't enjoy lifting those weights, and my daughters make fun of me because they're such wimpy weights. And then I ride my bike, either stationary or out there in the real world, to get some of those leg muscles going. And I've gotten to the point where I don't feel right if I haven't had that exercise, even if I'm only spending total of half an hour a day, doing the little that I can do. And yeah, I really do think it's played a huge role in my slow and somewhat unsteady recovery over these past 10 years.
Which you
Thank
have
you.
recovered.
Well, I've recovered to some extent. I'm still in recovery, but yeah, I'm never going to get back to running great sprints or whatnot. That's just not on the cards. But I'm learning to accept that doing a small amount is way better than doing nothing.
True. There you go. Well said.
Thank you. Thank you both.
Absolutely.
I'm
Thanks for the
going to-
invitation. This was really fun.